Like the thing with the timing? No? Okay.
Okay.
I'm not going to touch it. Well, thanks everyone for people who are here in person and for people who are on the go-to meeting. So my name's Terry. Michelle's here with me too. And we're going to be splitting up. Today we're talking about discharge medication reconciliation. So we've kind of done this clinical forum. We'll do pretty much a triad. So we did one a couple of months ago about admit MedRecs. We're going to do this one specifically on discharge MedRecs. And then later on, Michelle and I are going to do one specifically just on SNF discharge MedRecs, because it's a really something we've been working on with through rotations and something we've come across a lot. So just to start out, as most of us know regarding our TOC program here, we kind of have all these different components that we try and integrate, and all those people working on it all the time. So the one we're going to focus on today is the discharge MedRec. It's something we've really been trying to encourage our staff pharmacists to do. It's one of those things that even on people who don't have some kind of best practice medication history or admit MedRec, we can still do a DMR on them. Just to really help make sure that their orders look okay once they leave either to their home or to some kind of facility, just to make sure that everything looks okay on discharge. So we'll kind of walk through the discharge medication reconciliation process. I'm just going to kind of give you an overview, and then Michelle's going to kind of go over what it looks like in Epic. Thank you for those who brought your computers. We just want to make sure that you guys have everything set up with an Epic if you guys decide to do this while you're on rotations or doing inpatient stuff, whatever you want to do. So overall, how many in here have done a DMR? Raise your hand. Juan, put your hand down. I know you haven't done a DMR. So thank you to those who have done a DMR. So pretty much, as we all know, it's reviewing all these orders that we have, specifically the discharge orders that you see, and ensuring that the medications that are included are appropriate for this patient upon discharge. So really, when we're conducting the DMR, we're looking at two different things. We're looking at that after-visit summary, so specifically what those discharge orders look like. And then we're also looking at what they've gotten inpatient, looking at kind of at the notes, seeing what the provider said. Did they stop things? Did they start things? Were there reasons that they did these things? Looking at labs, making sure that renal function looks okay. So kind of a little bit of everything, taking them all and kind of compiling them together to make sure that the AVS looks as clean and as accurate as it can. Some kind of key things to watch out for when we think about DMRs. There's a lot of different things that can go wrong that, providers just could click something wrong, or maybe they would continue something that shouldn't be continued. So looking at dose adjustments is a big one, looking at renal function or other labs that you want to take into consideration. Any medications that are held, blood pressure meds are really common that they're held in-house, but then they start them on outpatient. So kind of taking that into consideration. PRN medications is a big one, so any kind of pain meds or other nausea or whatever they need. Medications resumed. Quantities is a big one. We'll talk a lot about that today, as well as stop dates. These tapers that people do. Is it clear for the patient what they should be taking? Is it clear for anyone reading this, for their caregivers? Making sure everything makes sense, even to you, as a provider, making sense. It's very easy to read. And then looking at the pharmacy too, if they're going home, making sure the pharmacy's open. That's a big one too. And if they're using our pharmacy, that everything's covered, insurance coverage. It's a pretty big picture thing, but we're going to look at all these details as well. All right, so I'm just going to kind of introduce all these components of the discharge MedRec, and then we'll kind of go into Epic and look at them in Epic as well. So to begin, we're going to look at the AVS, so the after-visit summary. So we've all seen this. This is kind of our gold standard for what those discharge orders actually look like for the patient. This is really what we as a TOC team, we also teach the medical interns about this. This is what everyone should be looking at to actually say, here's what the discharge orders are, here's what's going to the patient. This is our ultimate gold standard for the end. So we're going to look at all these different components. Are they starting new medications, changing them in terms of dose adjustments, continuing them, or stopping them? So looking at, do they fit into those correct categories? Does everything make sense on there? And then also thinking about our pharmacy as well. Is it sent to a pharmacy that the patient wants to go to? Is the pharmacy open right now? Can they go right now and get them? Does everything make sense with regard to that as well? And then comparing that AVS to our inpatient MAR is really where our DMR comes into play. So looking at not just our scheduled medications, but also looking at our PRN medications, any pain meds, do they need those outpatient? Have things been held? Were things stopped a couple of days ago, but they want to put them back on for some reason, kind of looking at that MAR and making sure that everything makes sense to you. All right, so overall the DMR process, kind of just going through where does it start? So it starts by the discharge orders being placed by the primary team. So when we actually go into Epic and show you guys, you know, if you don't already have this within your patient list, it's important to have that discharge order in there. That's really going to tell you to think, oh, now I need to do a DMR on this patient. So this is what's going to tell you that they've placed the discharge orders. And this is where you're then going to start the DMR process. Something else to look at is our TOC risk score. So that's something that I'll go into a little bit more detail on the next slide, but this now comes up, as you probably all seen, this now comes up within your patient list. You can add it into your patient list. And what it breaks it down into is that we have all these different components of our TOCRX risk score. So this is something we've compiled ourselves. We found that all of these are indicators of 30-day readmits. They're putting patients at a higher risk for a readmission, which is why we classify them in terms of these risk stratifications. And then within your actual risk score, within your patient score, if it's red, that means they're high risk. Yellow, that means they're medium risk. And then green, it means they're low risk. So we classified high risk as greater than or equal to 8, just as an FYI. So that's what it's going to look like. If you're actually in Epic, then you can also see kind of what the breakdown is. Sometimes you can hover to discover as well if you just put your cursor over the TOCRX risk score as well, just to see what components are actually contributing to their high risk score. And then just some kind of breakdowns of what actually, most of them are just 1 point, but we do have some that are worth more points. Specifically our discharge disposition, if they're going to a SNF or an LTAC or a rehab, that's going to give them automatically 8 points, so put them at that high risk category. All right, great.
So I'm going to talk a little bit about the documentation and kind of what your Epic looks like, and we're going to go through how to set up your different lists and add the different things that you need to do a DMR for these patients. So there is some documentation that we as a TOC team do so that people don't duplicate work, and so we'll kind of go through that. We'll talk about where to find the AVS, how to print and preview that AVS. We'll talk about writing a progress note, documenting our intervention and our work within the pharmacist intervention flow sheet so we can keep track of how many people we're getting each month and kind of what we're doing and how much time we're taking to do that. And then we'll talk about updating the TOC pharmacy follow-up note, which is kind of a new thing for us. So our first thing, just like Terry mentioned, we use the discharge order column to make sure that we can see that this little clipboard has been placed within that column to then give us the heads up that this patient does have discharge orders to go home. So I don't know if you guys, is that something that you normally have within your Epic list right now? Okay, yes, standard. Okay, and then the big thing too is the TOC pharmacy follow-up note, which actually is pretty new for us as a TOC group. So adding that, you could see if they fall into the heart failure, HIV, or SNF realm, and we have people that are actively working on that, it may be important that you have that list so that you can see that Terry or Trina or someone else has already been doing this, even though it's a patient that you're following, so you can communicate to see who should work on that. And so we'll talk about, I guess, how to enter that now in terms of adding that to your patient columns.
Use slideshow button on the screen.
Use slideshow button. No. Use this. This.
So sorry for that.
Can you see that now? They couldn't see anything. It was completely black.
Yeah, start.
Okay. Cool. So I'll just start. So just from the Epic documentation, so just to give you a heads up. So we'll communicate that the DMR is in process, preview AVS, write progress note, document the intervention, and update. So really, this first slide is what's most important, communicating and visualizing that a discharge order has been placed. So again, make sure that you have the discharge ordered column within your list. I think can we pull up? Can I pull up Epic on here?
Close your PowerPoint.
So I'll pull up Epic just to make sure we can walk through. Does everybody know how to add and edit your patient lists? Okay, so we don't need to do that then. Whatever. No.
Maybe just CWP.
Okay.
Just say yes.
No.
Oh no, that's fine.
What?
We'll start it.
Oh.
you push that? Close that.
Close this.
I'm going to show them one of your lists.
Yeah. So here's an example of our heart failure team list. And if you need to know how to edit that list or any of your lists, you'll go to the top left corner of Epic, go to Edit List, Properties, and then you just need to put in what you need in terms of here. So TOC Pharmacy is what you would search to add the TOC follow-up. Oh, probably because we already have it, right? Oh, why is it losing this?
Oh,
That's okay.
Oh, it's okay. Okay, so just sorry, here, you go ahead. It's more important one that you set up your list to be TOC appropriate. What? Oh, okay. Okay, so yeah, it's called TOC Pharmacy Follow-Up List if you want to add that. And that's where we document that DMRs are within process. And the way that we do that, kind of consistent with our AMR, TOC, heart failure, HIV, we do the open brackets, and you type DMR, and then your initials, so somebody knows that the DMR is within process. The bracket without the X means that it hasn't been done yet, and so that's appropriate as you're doing your DMR. Everybody good there? Okay. In terms of your AVS, is this something that people commonly have on their Epic sidebar? Yes. Okay. Okay, so we don't really need to go over this, but it is important to make it your favorite, so it's something that's easy to see, and you can do that by the information here. But just for the sake of time, I won't go through how to do that. And you can click on the star to make it one of your favorites. Okay, so you'll want to bring up the AVS. I normally copy it into an Epic or into a Microsoft Word document so I can easily see the AVS versus the inpatient MAR, so I can easily compare the orders. So then once you compare the orders, you will write a progress note. Have you guys written a progress note for discharge MedRec before, too, with your discharge MedRec? Okay, perfect. So the big thing here is just to remember that the search button within the kind of search bar, you just type in MedRec, and you'll see all the different options. Here we'll do discharge MedRec. If you don't want to remember that, you can add it to your favorite list one time, and then you can always just go to that favorite column and pull it up versus having to remember, what's it called again? What? And then the template here is what that discharge MedRec note will look like, and just based on your findings for that patient or kind of your process within the discharge MedRec will kind of guide which different option you click here. And so normally I try to do, find my list of problems, I'll page the team, regardless of how busy it is. I may just do a page primary team, have all my recommendations on there. So when I'm working on my other patient and the team calls back, I can easily know what I need to talk about. What?
Show the slideshow.
Oh, crap. Sorry, what did I miss? So you just talked about AVS. So hopefully everybody has the AVS, on their Epic sidebar. Then in order to write a progress note with your DMR, because you want to document everything that you do, within the note, just like a typical Venco note, instead of writing Venco, you would type in MedRec. And these options will appear here, and you'll obviously pick discharge MedRec. You'll see the tab to the right of that labeled favorites. So if you don't want to have to remember this ever again, you can literally add this to your favorites and it'll always be there. And then the template here is just kind of showing you what our discharge MedRec template looks like. Again, many ways that you can do this, but just for the ease of keeping up with your patients and everything that's going on, I normally do page, write all my recommendations, and then change it to discuss whenever we have come up with a plan for the different issues that I have found, just to document everything that goes on. And then in terms of after you kind of create your list, talk to the team, update that note to the appropriate interventions, you'll want to document your interventions and how much time it took. And so is everybody familiar with the pharmacist intervention star? Okay, so we won't go through that, but you will want to click on that intervention tab. For this one, since we're doing a discharge MedRec, you'll pick discharge MedRec. You'll want to log in how much time it took you to complete the whole MedRec process. And then we have different outcomes and interventions that are actually have been recently updated as well, if you haven't done this in a while, in terms of the different things that you can do. So they range from a number of things: adding a drug, changing a dose, taking off a medication that was inappropriate, communicating anything to the doctor, facilitating refill requests, facilitating Coumadin clinic follow-up, outpatient clinic visits. So all these things are listed here. So again, important that we document kind of everything that we do, just again, to keep track of all of that.
Where does it go, or what do we do with all this information?
Yes, we actually run a report every month to see kind of how many MedRecs are being done by the various hospital sites. We actually, Trina looks at La Jolla versus Hillcrest, staff pharmacists versus residents versus TOC versus, just to see how many people are helping out and how many things are getting done, and where best to kind of focus our education next to make sure we hit more people.
But is there like a reason this to get more FTEs or to get more TOC residents? Because this is going to take time to
Right,
document all this
for
stuff,
sure.
like, instead of just kind of.
I mean, the institution's looking at it as a whole in terms of our TC program and trying to make interventions. Hopefully.
Any questions about this? Pretty self-explanatory. It can be sometimes overwhelming when you just open that screen and you have all these buttons in there, but once you start using it more, it's pretty easy to use.
Yeah, and you'll kind of memorize which ones you're hitting a lot and kind of where they are within the system. But yeah, it does take a lot of learning and just getting within the process and developing your own workflow to make sure that you've hit all these different things, and to be consistent with it all as well can be a lot.
Can you go back and see this, that this was done on somebody?
Yeah. So yeah, one of our projects at the beginning of the year, whenever we didn't have all this education, was to go back and make sure that when notes were being left, that people were adequately documenting their intervention, so we could see, like, again, where the kind of barriers were to either teaching on rotation. Was it ever told to the resident? Make sure that everybody was kind of being consistent. And so from that, we developed education that we then kind of brought to our different TOC rotations, just to make sure that everyone's on the same page.
So once you document this, you'll open it back up and you'll see that at that time exactly, you can see who did it, what time they did it, and what they actually did. When you click on the thing on the pharmacist intervention flow sheet. Yep.
And the same data when I pull it. Intervention.
Have you thought about streamlining it all to make it so there's just one note instead of having this note plus the other progress note? To have it all.
Well, the progress note is for our physicians. Like, it's for this. This is for our own tracking. There's no good way to pull progress notes right now. Then I have to like manually go back and look at all the different progress notes. But this, I just pull the full one and it's like show the full in and I just look at it. So this is a lot faster now compared to our old item.
We're talking in the PK meeting about having progress note versus progress notes.
Yeah,
Mhm.
like,
Time.
that's
Yeah.
what UC Davis, and right now there's like, because the limits within Epic of in progress note pulling, you can't, like, each intervention would just be professional together. Based on like a full sheet or ID and all that stuff. That is what we do, like, say we need to pull full intervention, can you do it all in one?
Yes.
You have to keep going back and
What was the question?
So the question was, if you do multiple things for one patient, do you have to do a separate input for each for each intervention, or can you just do it all on one flow sheet? You can do it all on one flow sheet. The only difference is whenever we do discharge MedRec and education, if you do the education piece, you want to go back in there. You have to like wait 1 minute, so it's a different time within Epic to document that education piece. So that's the only time we do like two different interventions, just because it's two different things. You either compared the two orders and that was it. And then you want to also, if you do talk to the patient, spend that time, document that as well.
because I don't want to wait.
Yeah.
I'm just
Oh, so you want us to make it the same time?
No.
Epic won't let you make it the same time. So if you do your education and you go back and you're like, I want to document it now, you have to like either wait or I guess back time your interventions. I didn't even like do that. Okay. Any other questions here? Okay. And then once we do that, again, just to keep everybody consistent and on the same page in terms of where we are within the note process and to make sure that nobody redoes this, you would then go back and within that TOC pharmacy follow-up column, add an X to the little bracket, and that signifies that that patient is done, nobody needs to touch it, and everything has been kind of resolved. And so until you talk to the team and resolve all those interventions, after all that, then you can, again, put that X within the discharge brackets. Any questions there? And then we also just wanted to give you kind of a tidbit about SNF patients. Since these patients, they automatically get 8 points at discharge, regardless of what their disease states are or why they are here. And so we just wanted to let you know how you could identify that these patients that are maybe on your service or on your floor are actually going to a SNF. So again, all these patients will be higher than 8. And that will be documented within their TOC RX risk score. You can then click on the admission MedRec if you have that as one of your little tools, kind of where you see like glucose, anti-coag very quickly on your patient list. If you add admission MedRec, you can see the different points, and you'll see here the big one. I think this one actually has animations. The big one here is discharge dispo, and so again, this includes LTAC, rehab, SNF patients. And so that's one way to clue you in, hey, maybe this patient's going to a SNF. However, we all know that sometimes the discharge process is not super smooth. Sometimes the medical residents will push SNF or rehab, and that was originally the plan, but now they're actually going home. So we always double check that these patients are actually going to the SNF. And one way that you can double check is within the AVS. Instead of saying that it's going to Jacobs Pharmacy or Hillcrest Discharge Pharmacy and that's where their refills were sent, it'll have this little blurb about ask your doctor where to get these medications because it's not available yet. And this is because the SNF, for the most part, will provide medications to the patient. There are some stipulations to that, including HIV meds, high-cost meds, where they don't have an adequate supply and just don't keep that stuff on their formulary all the time. But for your information now, that's kind of a second check that you can do to make sure, hey, it looks like and it seems like this person's actually going to a SNF. And really kind of the big double check, if maybe more worth your time, is that every patient that's going to a SNF, and maybe Terry can back me up on this if this is still the case, they'll have a case manager note because the case management is obviously involved within this patient's care and is helping figure out which SNF or LTAC these patients can go to. If you double check the note section, there'll be a case manager note relatively close to the top in terms of preparing for discharge, and you'll see within this note it says what SNF location they're going to, and from that point you can basically assume that yes, in fact, this patient is determined to go and will be going to a SNF.
It's also kind of nice too in this case management. Oftentimes they'll tell you what time they're leaving. So if you're like, doing 1,000 things, you're trying to do a DMR, you can oftentimes look at this note and say, oh, it looks like they're leaving at 4. I have a little time to kind of get things together. Just
Yeah.
What was the big thing about the difference between SNF and home?
We're gonna go over them in a second.
Yeah. So the big good transition. So there are some differences that you should be aware of in terms of these dispositions versus just going to home. So one of the big things is that instead of the patients getting an AVS like they would if they would go home, these patients obviously don't get an AVS because they're not taking care of their own care to wherever they're going. Instead, these patients get a discharge packet. And so this discharge packet has a number of different things. It has the discharge orders, it has the last progress note, again, for the doctor to help take care for this patient. But within that discharge packet, they do have the discharge orders, which are basically the same thing as an AVS, just a little bit of a different setup. When you're comparing the orders, though, you can still use the AVS, but just know that the terminology is a little bit different. So normally when the med residents place the discharge orders, they print out and have to sign this packet, just verifying the accuracy. So if you go in and do a discharge MedRec and find that there's a number of things wrong, you will not only have to continue to talk to the team like you normally would, but at the end of that, you'll say, okay, since we're making these changes, after you make these changes, can you reprint out that discharge packet and re-sign it so you don't just make the changes verbally? It changes on the AVS with an Epic, but that's not what's given to the patient to go to the facility. So that's kind of some special wording and terminology that does need to happen to make sure that your changes get implemented before the patient leaves. If they end up leaving and the changes aren't made, you can always take the extra step. It takes some time, but you can fax over the new, just print off the AVS and fax it to the facility to say, hey, we made some last minute changes. They left before. We could get this printed off, but here's what the doctor intended. And then normally they'll take that instead. In terms of, like I think we talked about the AVS communication with outpatient providers. Again, they don't get an AVS. They get this discharge packet that goes with them. One thing to note, we do have a SNFist program, which again, we'll talk about more in our SNF discharge talk, but we have 3 doctors that we work with, Doctors Neal, Gonzalez, and Wynn, that are UCSD SNFists. And so if these patients end up going to a facility and you see within the case management note that they're going into Doctors Neal, Wynn, or Gonzalez, we actually will route, and we'll talk about that, we'll route our discharge MedRec note to them just to make sure that they're aware of the changes that we made and just to clue them in, I guess, into what's going on. In terms of supply of medication, so again, most of these medications will be supplied by the facility. I always double check ones that you don't see very often, HIV meds, which normally Shannon will take care of before they leave. But anything that looks funky or that you're questionable on, you may want to double check that the facility can supply those medications to the SNF. If not, we can just send an order to the discharge pharmacy. It can be brought up to the patient before they go. And then the big one that I want you guys to be aware of right off the bat is medication quantity. And so this, we always want to double check within the AVS that patients we normally do like a 30-day supply for most chronic medications. And so with these patients, because they're not getting an actual script, an actual bottle of medication, especially for things like antibiotics, the day supply actually at the SNF does not matter. So these patients say going home on Bactrim 1 BID, it says number 6, and in your head you're like, okay, yeah, that's 3 more days of therapy. The SNF will understand that. No, the SNF does not even look at the quantity because it's not an active prescription. So within your AVS, you have to say Bactrim 1 tablet twice a day through 6/8. You have to kind of actually put in a stop date within the admin instructions to make sure that the medication's not continued. So I know at the beginning of my SNF rotation, I would call the SNF. It would be 10 days later, and they would still be on these antibiotics when it said a quantity of 4. So you think, okay, well, 8 days ago, you should have been off this med. They're like, no, there's no stop date, whatever else. So we just want to make sure that things like antibiotics, prednisone tapers, amiodarone loads, that then should be converted just to the once a day. Things like that, NOACs, if they're being treated for a DVT, you always want to put the date of transition or the date of stop just to make it, again, very clear for the SNF and for the nurses there.
Isn't there a physician on the other end that's writing these orders? Like, these are just our
So,
FYI,
yeah.
on this.
Yeah, so that whole, so we can't control that process, but yeah, normally when they get discharged from here, an LVN or an RN will receive this patient. They're going to be the ones that are looking at the sheet, and they're the ones that call the doctor who is in clinic or doing something else. They're just like, okay, do whatever it says on the paper. So we have found, in order to kind of cover our butts and make sure that it's as clear as we can be for nurses or LVNs who, don't have all the clinical knowledge that we might have, just to lay it out for them, be as specific as possible to help decrease any risk of medication error.
So how often does the doctor see the SNF?
Yeah, so, and then that's the other thing. So the doctor doesn't have to see the patient for they have to see them once every 30 days. So, and most of them, say the patient goes to the SNF on 6/3, but the doctor was there on 6/2, literally that patient will not be actually seen by a physical doctor until 7/3, and they've been there for 29 days. So we're lucky with our SNFists, they'll see these patients within 72 hours of being to the facility, but the general consensus for everyone who's not seen by these 3 people, who knows when they're going to actually be physically seen and assessed, and their medication orders are actually going to be looked at in person versus just like over the phone by a nurse saying, here's what they ordered, is that okay? And they're like, yeah. Yes. Yeah. So I normally say, like, if they're in a bind, I kind of try to listen to what how flustered the doctor is. If they were super nice and super willing and, oh, thanks for calling, I'll say, hey, you're going to have to re-sign the packet. Can you do that, or do you want me to call the nurse? Otherwise, if they're in a hurry and they say, oh, I have a million things, I'm in clinic, I'm in the OR, trauma team, I'll say, okay, I'll have the nurse reprint that packet for you. But we always, if you can, try to make them do it. Yes, yeah. They had to sign it originally. They signed it originally and they know what the packet is, but they don't immediately think like, oh, we're making changes, let me reprint off that packet. So that does need to be communicated to them. They still have to sign it. Yeah. And so I guess the minority of cases, if they're in the OR or something, I'll let the nurse know, hey, can we reprint the packet? The doctor can't come sign it. He's in the OR, but he verbalized these changes. And usually for me, I didn't have any problem with that. But ideally, we would want them, if they're still on site, to sign that packet just to justify that these are the right orders. And I don't think it's a big thing, honestly, that the SNF looks at, but technically you should say, hey, go re-sign these orders if you can. Yes?
Sorry, I don't know if this is a question,
No.
but does it have to be the attending that has to sign this packet?
No.
Because I've had questions about that green sheet for IV antibiotics. Well, who has to sign it if that doctor isn't available? Someone else.
Yeah. The resident. Anyone on the team can do it.
Oh my god.
Yeah, just an MD.
Oh, yeah.
Okay, so like direct questions.
Oh, sorry. Do they have any questions on there?
I just signed it right
Okay. We'll go on, and if they do, we can answer at the end. Oh. Okay. And so this is just an example of what you would want your AVS and the orders within the AVS to look like, and kind of what we verbalize to the doctors as to what we kind of want. So here's an example of an antibiotic and a Coumadin bridge. And so you'll see here we literally lay it out for them: administer 1 milligram per kilogram every 12 hours until the INR is 2 to 3 for 2 consecutive readings. You'll see the Moxie, it says quantity of 6, which you would think 6-day supply. Well, we add in a stop date here of 6/17/17. And then warfarin, again, we try to be as specific as possible. Take 2.5 milligrams every evening. INR goal is 2 to 3. Please draw INR daily because we're in the bridging process. Again, specific as possible. Just pretend the patient's like, the nurse is like not even within healthcare, and just be like very specific just to make sure everything is done, especially with these high-risk meds.
Can I say moxicillin for 6 more days?
Yeah, you can say for 6 more days too. That's another appropriate terminology. They understand that one too. But you can't just say take 1 daily, quantity of 6. They don't look at that.
You wouldn't do all this for regular discharge.
No, so for regular discharge, they're going to be picking up their meds from the discharge pharmacy with 8 tabs. I mean, you always say like continue until done, but since it's not like a physical bottle that they're getting, the SNF, doesn't make that connection.
So do you go in and type this in yourself, or you tell the doctor to do it?
So you want the doctor to do it. It's their patient. They'll try to pawn it off on you, and I would always say, well, I'm actually not taking care of the patient. I'm not writing discharge orders, but I can walk you through how to do that. We can walk you through how to have them do that at the end of this, just so you know how and where to guide them. But yeah, I try not to step in because it's not you're doing them a service. This wasn't your responsibility, you know what I mean? And so you want them to learn to do it so for the next patient they know how to do it as well. So some of it really is super dependent. So we asked about pushback. I'm sorry, I'm really bad at this. So Danielle was asking about pushback from the providers. And so really it depends on the provider. Some providers are like, oh my gosh, thanks for catching that. I'll change it right now. Some of them are like the ortho team, which is the most of your SNF discharges, I would say. Oh, I'm in OR right now. I really can't do it. Can you do it? Some of them get mad that you're doing this because it's not your patient. So really I would just try to read the situation. Like I would rather do it and call the nurse and have her print it out than it not get done. And I would be willing to do that. But I know some days you don't want to just get in the habit of doing that and just putting that on yourself because it does take time and all that stuff. But I just would try to read the situation, and if they were nice, I would offer, and if you could tell they were busy and have a million things going on, I would offer, but ideally it should be up to them.
And to your other point, I mean, you can always just say, I always say to them, you know, if they ask about the stop day thing, sometimes be like, wasn't that clear? Shouldn't they know that? And I always say, okay, well, if they go to the SNF, what's going to happen right now is they're going to continue this Lovenox for an indeterminate amount of time because they don't know that. So I mean, just explain the consequences of what's happening if they don't do it. And they're usually pretty good.
So if you fix it for them, then you reprint it, but then I thought they're supposed to sign it, so then they won't have a signature stuff.
So the question is, if you make a change and you're having them change the instructions, how does it work if they don't get a signature? So it's supposed to have a signature in a perfect world. I don't know really how it works at the SNF. That I don't think that they're gonna. So ideally, yes, I think from a law standpoint, they do need a signature from the doctor. Sometimes it's not possible. The doctor's off campus, off site, did the discharge orders, thought it was right, left, OR, whatever. And so in that scenario, I'll say, okay, you're in the OR. Let me just reprint the list off. I'll tell the nurse that you verbalized these changes and that you're okay with everything. And I haven't doing phone call follow-ups to SNFs. I didn't find any issue like, oh, it wasn't signed. We didn't put any orders in. I never found that to be an issue, but you want to try to promote that signature part because it's technically part of the process, but it's not an end-all be-all.
Yeah, the best practice is to, if there's any changes on the abdomen in regards to the medication, it should be reprinted by the nurse, and the physician will physically go there. Most of the physicians actually know, like the medicine attorneys all know, like, oh, I have to go back and find the discharge summary. They're like, oh, now I have to go back and find the discharge summary. It gets kind of hairy with surgeries. Sometimes they're like, I'm in the OR, and then the nurses are like, hey, well, there's nothing to do about that. So they still fax the latest medication list, but it's not like there's a signature. But it's best practice is the signature on all orders.
So best practice for discharge to a SNF, ideally you would want the resident or attending to come and re-sign your new discharge packet. But if they are in the OR, off-site, in Hillcrest, and the patient's in La Jolla or whatever else, it's okay to call the nurse, say we've made changes, they've been okayed by the doctor, but he is so-and-so not on campus to sign the packet. Can you reprint the packet and give it to the patient before they go to the SNF? And there's usually no pushback in terms of the nurse saying, oh, it needs a signature. Best practice, though, would be to continue to use the signature if at all possible, and if they're on site, tell them to go sign that packet, but you'll have it printed off by the time they get there, type of a thing.
Because when you reprint it, you're not putting spoke with Dr. So-and-so. There's no documentation on that sheet that you.
So the discharge packet is reprinted. So, and from my understanding, there's like a signature page within that packet saying that the doctor clarified that everything is accurate, all the meds are accurate, and everything. So yeah, it is, the signature piece is part of that packet that they'll go reprint.
In that reprinted signature packet, that piece, will that have the doctor's name that originally put those orders in?
Yes.
Yeah, it won't just be like a blank.
No. Right. Okay. Oh, and then we'll talk about note routing, so the last piece, and then we'll do kind of a case here to sum up. And so one thing that we do, like I mentioned, we always route our discharge notes to the SNFists, so Dr. Neal, Wynn, or Gonzalez, if they're going to a SNF facility, which we determined by that case management note. But you can also forward this along if they're a heart failure patient and someone's going to see them in clinic within the next couple of days, and you want to make sure, hey, that they went to a SNF, make sure everything's right. Hey, it's a Coumadin clinic patient. I want to make sure that they have follow-up after they leave the SNF. You can always route any note to any provider, any resident, any nurse practitioner within the UCSC system so that they can actually see that note within the inbox and be kind of clued in as to what's going on. And so the way that we do this is if you go kind of to the progress note section where you just wrote your note, there's actually an option in the top right corner called route. If you click on that, it'll bring up this box here. And in the top right corner of this box is a little search button. And you can add in any person by searching their name. And if you click on send, it'll literally send your note to them so they can just be kept within the loop with the changes that were made, or, hey, they're going to see you in clinic tomorrow. This wasn't made before they left. Can you make sure to follow up? Anything like that can be routed and can be helpful for people who will see the patient in the future. So do they look at those notes?
Have you heard, like, the doctor?
Yes. So the question was, do people look at these notes? So for sure the SNFs, they rely on these notes. They say that this is honestly the most important part of the discharge for these patients. I know I do a lot of these notes to Megan Lang to say, hey, they did a referral, high risk, see them soon. And she's super grateful and will reply in 5 minutes. Otherwise, those are kind of the big two people that I route to, and they've seemed to like it and know they'd rather be kept in the loop than have to search through on their outpatient Epic to try to find this note, however that happens. Okay, so I'll kind of let you guys practice with this patient case that Terry's handing out.
So we're going to hand out to you guys, we're just kind of go over the patient case. We're going to hand out to you, it's going to be an AMR progress note, and then we're also going to have an ABS, and then an inpatient MAR, labs, and an anti-coag flow sheet for this patient. So we have Mr. John Doe. He's a 53-year-old male. He came to the ED with worsening chest pain, past medical, CAB, status post stent, 2 years ago, hypertension, AFib, and type 2 diabetes. He's now being yes, sir. Wow. All right, so we have this patient case. The patient is now being discharged home after a complex hospital stay. Just some points to think about during his hospital stay. He was found to have pneumonia during his hospital stay. He will be discharged on Augmentin for a total of a 7-day therapy. His INR was consistently low, and the team would like to bridge with Lovenox on discharge due to being high risk. He has a TADS VASC of 3, and his blood pressures have been running low. However, he has been tolerating metoprolol and Imdor. So you decided to perform a discharge MedRec for John Doe because the primary team told you that they made a lot of changes to medications, and you want to make sure everything looks okay. All right. So first in Epic, where would you go to find John Doe's ABS? So we kind of talked about this. You probably have it in your favorites, right? So it's going to be on that toolbar on the left-hand side bottom. It's probably one of your saved favorites. You're just going to open up either Preview ABS or Print ABS, either one, whichever one you want to choose.
This is after the summary.
Correct. What are the resources that we want to be able to use to perform the DMR besides just your ABS? You have some of them in front of you, right? Your MAR. Progress notes potentially, if you want to kind of read back what happened with the patient. Great. Maybe some labs that we might want to look at. Maybe for this patient, we might want to look at our anti-coag flow sheet because he was on warfarin. It's kind of all of these different things. All right. So at this point, we'd like you guys to actually perform the DMR for this patient. So look at your AVS and then kind of go back through your what actually happened. So we already performed an admit MedRec for this patient. And so I provided you with the progress note for the AMR. His PTA med list was updated, and so everything should be correct on there, but you can read the AMR progress note just to see what we actually did for the PTA med list. And then just look through his MAR, make sure everything was continued or not continued. That makes sense. And then we'll kind of go over how everything. Okay, so people on the line. So what I handed out to people here, which we can send out afterwards if you guys would like to try to do the DMR on your own, is I handed out to them for this patient. I handed out the AVS, I handed out the inpatient MAR, I handed out the labs for the hospital stay. Oh, and Michelle's going to email it right now. And then I I handed out the anti-coag flow sheet as well as the AMR progress note. So they're just going to kind of look through things and see if there are any discrepancies that they find. So just take a couple of minutes, write things down and then we'll just kind of talk about what we would write in our progress note, or if you want to talk to the team about certain things. Don't forget to send the progress note too. It's just on iShare. So you're comparing the ABS to the inpatient med orders.
ABS?
That is the ABS, correct? I know the name's different. That's out of Mark's fun. Make sure everything makes sense to you. Was he on meds inpatient that he's not being sent out on?
Oh.
What'd you say?
What's going on?
World.
What is it? Right. It's on iShare. You just tell them that it's on iShare? Tell them they can go on to iShare. You just have to tell which documents because there's like a bunch of them. Here, I'll let you
Bring it up on iShare. Sign in to CWP again.
But like then toggle every 2 seconds between all of them. If you guys on the line want to practice doing this while we're here and can answer questions, if you want to get on iShare, we have everything updated and uploaded on there. Dude, are you? So if you go to TOC, your bottom right corner, resources and training material, MedRec training, patient case files, and if you look at 02, so that would be the PTA med list. Looks like this. See, I don't know why. Get the PTA med list. The MAR history is what we're looking at. See, we have lab values on there, the anti-coag flow sheet, and the initial AVS.
Just missed the MR.
Huh?
I'm just really good. It's Indonesia MAR,
MAR history.
All the PDF.
It's 2. Oh, they don't, yeah. So MAR history, lab, anti-coag, AVS.
Where's this patient going?
What's going on?
Good question.
Shake your head.
She'll know where it starts. I need to set it up.
I mean, I showed them. I don't know how you see that anymore. Marcy, Lillian.
I think they got it. Do you want to put that down? So,
What are you going to show them? Nothing? I guess PowerPoint.
yeah, and then we push the right button.
Yes. Done.
I'm just done. RIP.
Andrea's done.
Oh, yeah. All right.
Aw, we're running out of time.
Okay.
Go back to resident. Yeah.
Why doesn't it go down?
Go back to resident.
Whatever. You guys ready to go through it? Okay, so here's just a reminder. Here's the AVS, inpatient MAR, lab values and anti-coag flow sheet to help you develop a plan. make sure you're okay with the plan.
And then this is just what you would do in Epic.
Yeah, so then within Epic, obviously you want to communicate that your DMR is in process. Print and preview the AVS, which you've already done. Write a progress note. And again, here's kind of what the template looks like for that.
Before we go to the next one. All right, so I've come up with a mock progress note that I would write. So let's talk a little bit about kind of some of our discrepancies that we found that we either want to talk to the team about or that you want to just fix, or how do you want to do? So we can just go around the room. What do you guys have? Just name one.
7.5.
So what about it?
All right.
Okay, so the warfarin 7.5.
I got one.
So what have they been getting in house?
7.5.
They've been getting 7.5 in house. Okay.
INR subtherapeutic.
INR subtherapeutic. Okay. So are we sending them out on a bridge?
We are.
Okay. All right. So we'll talk about that in a second. What's the problem with the warfarin though?
Should we change to 7.5?
Okay. I'm just making sure.
I'm on it.
Okay. All right. So we have the warfarin. What else do we have? Perfect. You're super on it. So that's why. So kind of this goes into our AMR talks. That's why we.
You want to sit right here just in case people are
Oh
listening?
yeah. So that's why we gave you the AMR progress note. So that was something that the patient was taking differently. So we want to clarify with the doctor how they want to do that in the outpatient setting. Perfect. What other things do we want to talk to the doctor about?
Time to start the Lebanon.
Yes, Kat. The Lovenox. Okay. All right. So yes. So that's a big one. We see a lot of the times weird syringe sizes, weird doses. All right. So we want to clarify what dose are we giving, what syringe size, how long are we doing it, when to start the first dose. That's a good one. Did they already get the dose today? Should they start tomorrow? Great. Wonderful. What else?
Library.
Okay. So Brittany mentioned that one already. Lisinopril. Okay, so what about the Lisinopril?
The patient wasn't taking it in-house, and they kind of were using it there instead. So maybe just clarifying if that's something they really want to continue.
Perfect. Wonderful. So held in-house, not really sure why, is there a reason? Should we continue it on the outpatient setting? Wonderful. Anything else? What, you want your iron? You want it back? All right, so he was getting iron, inpatient, not continued on outpatient. Wonderful. Anything else? Are we all good with our augmentin dose? So actually, well, I can go back to this slide. So I told you that they want to do 7 days of treatment. So, so they actually.
That wasn't written down.
Everything on your handout gives them
All right. All right. So I think we hit everything. So this is just a mock template of what your discharge note would look like. So, you know, what Michelle already said, I would use the page primary team. I page the primary team. And usually when I page the primary team, I just say, look at the discharge orders and have a lot of questions. Please contact me back. You don't need to write all these things in there. They're going to be overwhelmed. So, so then you just kind of put down your notes. I usually pen my note. And then when you actually hear from them, you talk about things, and you can go through and say they updated the day supply, they updated the SIG for the enoxaparin, they wanted it to 120 daily, the glyburide they wanted to keep to daily, they discontinued lisinopril, so all of the things that you wanted them to do. All right, perfect. Any questions about writing the progress note, kind of how you put that stuff in there, doing the DMR process? How is the DMR process for everyone? Some people are super comfortable with it. Some people not so much, which is fine.
You want to point out
You'll get more comfortable with it.
the warfarin 5 milligram that you want to try to stick with.
Oh yeah, and then for the warfarin, something to consider. So he was taking 7.5, but we want to try and stick with maybe their, you know, what tablet size they had at home, which is why you would want to give like 1.5 tablets. you know, that's a big thing for anti-coag, trying to keeping it consistent for patients. All right, wonderful. All right, so then finally you just document it in your flow sheet and update your follow-up note just to say that you did it. And then you're all set and you've done your DMR. And people are proud and the patient's going home with no med issues, which we love.
What would you do